Hi there, this is Nizul, and we'll be looking at cardiovascular disorders. This video will have two parts, part 1 and a part 2. So some of the objectives in this video will discuss, or we'll look at a brief overview of some of the heart structures that would be relevant to the content, the cardiovascular content related to this course. We'll also look at a brief overview of the cardiovascular system and discuss atherosclerosis, the pathophysiology, the etiology, and the pharmacological treatment. In part 2 of this video, we'll be looking at coronary artery disease and the pharmacological management of coronary artery disease. So just looking at the heart structure, some of the things that we'll be looking at is the parietal pericardium. And the parietal pericardium is that outer layer that is a fibrous layer and a serous layer. And just underneath that, you have the visceral pericardium or the epicardium, and that's really what lines the organ. So viscerum, always think about visceral as the organ. Lining the inner aspects of the heart, which then goes along with the valves as well, is the endocardium. And lastly, where our focus will be mostly in week 1 is looking at the myocardium. And not just looking at the myocardium, understanding that the myocardium is the muscle layer of the heart. And that muscle layer is what really supports contraction of the heart, supporting it as a pump. The myocardium is a muscle, and muscle requires an oxygen supply. And so in week 1, really what we're looking at is what is supplying the myocardium of the heart with its needed oxygen supply. And sometimes those vessels, there are diseases or problems with the vessel that is supplying that myocardium with oxygen. So this slide is looking at blood flow through the heart and the circulatory system. There are two circuits involving blood flow, the pulmonary circuit and the systemic circuit. The pulmonary circuit involves the lungs, and the systemic circuit involves the body. The pulmonary circuit is really involving the right side of the heart. So oxygen poor blood or deoxygenated blood, which is often depicted in this blue color, is picked up from the body and it's then taken to the right side of the heart. It would first enter into the right atrium. It then flows into the right ventricle, and then it goes into the lungs where it's now going to pick up oxygen. Once the blood picks up oxygen, most textbooks or theoretical images then depicts oxygen-rich blood or oxygenated blood as red. That oxygen-rich blood is now going to flow, returning to the heart, and it's coming to the left side of the heart. It's first going to enter the left atrium. It then flows into the left ventricle, and then via the aorta, it's now going to go to the rest of the body to oxygenate the body. A key thing to really point out is these two blood, or the oxygen poor and oxygen rich blood, never, ever, ever mixes. The heart, or the chambers of the heart, that is the right side and the left side of the heart, will be squeezing, contracting, and relaxing, quote unquote, pumping simultaneously, meaning at the same time. However, the blood never mixes. So the heart has the septum in the middle, which clearly separates oxygen poor blood from oxygen rich blood. So they never mix. So this diagram just really is taking a closer look at the heart, really kind of zooming in from our previous slide to look at the flow of blood through the heart and kind of walk you through the steps. So here you see at the bottom, blood oxygen poor blood or deoxygenated blood comes up, from which we're going to look in our next slide, the inferior vena cava, and then it comes into the right atrium of the heart, which is number 1. Blood is also coming from what we call the SVC, the superior vena cava, into the right atrium of the heart. So that's your oxygen poor blood or your deoxygenated blood or unoxygenated blood. It then goes through what we'll be looking at in a minute, the tricuspid valve, and into the right ventricle. From the right ventricle, this blood now goes and it's taken to the lungs, where it's now going to pick up oxygen. And from the lungs, you could see number 3, blood is returning from the lungs, and that blood now enters into the left atrium of the heart through what we call the mitral valve, previously known as the bicuspid valve, into the left ventricle of the heart, and then that goes via the aorta, which is number 5, to the rest of the body. So this really is looking at a closer look at the blood flow through the heart, really an expansion of the previous slide. So with this diagram, we're just going to go through some basic features of understanding the anatomy of the heart. And so when you look at the heart has 2 what we call AV valves or atrioventricular valves and 2 SL valves or semilunar valves. The 2 AV valves are the tricuspid, which we mentioned in the previous slide, and the mitral valve. And the 2 semilunar valves are the pulmonic and the aortic valve. So the tricuspid valve, like we mentioned in our previous slide, is located between the right atrium of the heart and the right ventricle. So this valve right here, this will be your tricuspid valve. The mitral valve is located between the left atrium of the heart and the left ventricle. So this valve right here is the mitral or the bicuspid valve. Now when we say tricuspid or bicuspid, is really their attachments. So what you can see here, there's 3 attachments on the right side. So that's the tricuspid. With the mitral valve, or which we used to call the bicuspid, there are only 2 attachments that are located. Some other valves or some other vessels, pardon me, that you're looking at is this blue vessel, this large blue vessel bringing blood up to the right atrium of the heart, is what we call the inferior vena cava. And for short, we say the IVC. The IVC drains the lower aspect of the body. And then above here is what we call the superior vena cava. And for short, we call it the SVC, and that drains the upper aspect of the body, so the head, the neck, etc. Whereas the IVC drains the lower aspect of the body, so it drains the limbs, the leg, the gastrointestinal tract, etc. is drained. So oxygen poor blood or deoxygenated blood is really primarily coming back to the right side of the heart via these 2 vessels, the IVC and the SVC. Once the blood enters the right ventricle of the heart, as you recall from the previous slide, that blood is now going to the lungs. And so they go to the lungs via what we call the pulmonary artery. And the pulmonary artery is the only artery in the body that will ever carry oxygen poor blood. So if you recall vessels and understanding the function of vessels arteries always takes oxygen-rich blood or oxygenated blood. The pulmonary artery is the only artery in the body that actually transports oxygen-poor blood or deoxygenated blood to the lungs to pick up oxygen. That valve that is located between the right ventricle and the pulmonary artery, so this valve right here, maybe I should use a different color. This valve right here, that is the pulmonic valve. The pulmonic valve is located between the right ventricle of the heart and the pulmonary artery. Once that oxygen-poor blood gets to the lungs, it becomes oxygenated, and it's now going to return to the left side. And remember what we said before when we discussed the circuits. Oxygen-rich and oxygen-poor blood never mixes. So that oxygen-rich blood or oxygenated blood is now going to return to the left side of the heart. And they're returning by these 4 little red vessels that you're looking at. And these are called the pulmonary veins. And again, going back to the function of vessel, veins typically carry oxygen-poor blood or deoxygenated blood in the body. So your pulmonary veins are the only veins that are transporting oxygen-rich blood, and they're bringing that oxygen-rich blood back to the left atrium of the heart. It's then going to go through this mitral valve into the left ventricle, and now that blood is going to leave, and it's going to go through the aorta. So this massive vessel right here is the aorta to the rest of the body. But it gets from the left ventricle through to the aorta via another valve. And so hidden right behind here, and I'm going to try to use another color, maybe more of an orange, this valve right here that is hidden, that is our aortic valve. And so that aortic valve opens, and the left ventricle is able to force its oxygen-rich blood or oxygenated blood into the aorta, which is then transported to the rest of the body. So it's really key. Just take a minute to review these 2 atrioventricular valves or AV valves and these 2 semilunar valves, understanding their anatomical location and understanding where they're placed. So just to recap, the tricuspid valve is between the right ventricle, the right atrium, and the right ventricle of the heart. The mitral valve is between the left atrium and the left ventricle of the heart. The pulmonic valve is located between the right ventricle and the pulmonary artery, whereas the aortic valve is located between the left ventricle and the aorta. And so looking at this diagram, this is really showing everything that we captured in our previous slide. It's showing you the superior vena cava, the inferior vena cava, the tricuspid valve, the mitral valve, kind of depicting where the right atrium is, the right ventricle. You're also able in this diagram to see the septum, which separates the right chambers of the heart from the left, allowing or preventing oxygenated blood and deoxygenated blood from mixing. But bringing us back to week 1, really what I want you to look at is what we call the myocardium of the heart. And so when we look at, or the muscle part of the heart, and what you could see here is the myocardium is very thick and very strong when we look at the left ventricle, whereas we see a smaller or thinner muscle on the right ventricle of the heart. And so when you kind of think this through, that makes sense. The left ventricle has to really be strong and force blood and pump blood because it's sending that oxygenated blood to the entire rest of the body, to all organs, the liver, the kidney, the brain, etc. So it is expected that that myocardium is really thick, very strong. And remember we said earlier, the myocardium is the muscle. And the muscle allows for contractility to force that blood out of the body. The right ventricle, yes, has a work to do. It has to send blood to the lungs, but it's only going to one organ, the lungs. So it doesn't have to be as thick, muscular, and strong comparatively to the left ventricle. So when you look at the myocardium on the left side, it's very thick versus the right side of the heart. So as we mentioned before, the myocardium of the heart has its own blood supply. And so there are the vessels that supply oxygenated blood to the myocardium is called the coronary arteries. For the purposes of this course, you are not required to know the different names. The only thing to understand is we have a right coronary artery and we have the left coronary artery. So here you can see the left coronary artery and the right. The right and left coronary artery obviously have tons of branches. For example, we have the circumflex, the left anterior descending, etc. It's simply for the purposes of this course, understanding there's a right and a left. And if you can see on this diagram, where they are coming off of or where they're originating from is the base of the aorta. So these lovely coronary arteries are really coming off the base of the aorta. What you need to understand is the myocardium has a full blood supply. And what do I mean by that? It receives oxygenated blood, and just like the rest of our body, once we utilize that oxygenated blood, we're going to make waste. And generally waste is carbon dioxide and water from utilizing the oxygenated blood to make energy or ATP. The myocardium is not any different. So the myocardium will get its oxygenated blood from the right coronary and the left coronary artery. Once it uses up that oxygen, the waste product that is being made is then going to drain, also in the myocardium, into these things called the cardiac veins. So it's going to drain into the cardiac vein, and then from the cardiac vein, this waste product from the myocardium will then drain into coronary sinus, and that coronary sinus has a little opening in the right atrium of the heart. So if you were to ask me, there are three vessels or three things that brings deoxygenated blood back to the right atrium of the heart: the superior vena cava, something that's not pictured here, the IVC, the inferior vena cava, and inside there's a little hole as well, which is the opening to the coronary sinus, draining oxygen poor blood from the myocardium of the heart. So the coronary arteries, they are located at the base of the aorta. And so you want to ask yourself, when do they fill with oxygenated blood to drain it into the myocardium? During systole or diastole of the heart. So remember, systole is contraction. So in the cardiac cycle, we have the heart goes into systole, which is contraction, and the heart goes into diastole, which is relaxation. And so when does the coronary artery gets filled? It gets filled in diastole. So when the heart relaxes, then the oxygenated blood that was heading to the rest of the body, some of it is going to flow back, and that's when they're going to flow in to the right and left coronary arteries. They're going to distribute themselves, supplying the myocardium of the heart. Because remember, the myocardium is muscle, it's a living tissue, it requires oxygen. So anytime the demand in the heart increases, or the workload, so start to think about things that will make your heart work harder. So your heart rate goes up, your heart is working harder. So you're running, you're doing activities, stimulants as well, that will increase your heart rate. So illicit substances or drugs, smoking, stress, anything that would increase the heart rate means that the faster the heartbeat, the more it's squeezing, the more it's contracting, the more oxygen it's going to need. So it means that those coronary arteries need to supply the myocardium with lots of oxygenated blood in order for the myocardium to receive enough oxygen to do the work that is being demanded of it at that time. So the heart has an electrical, intrinsic or built into it conduction system, and the heart requires, in order for muscle to contract, there must be electricity first. So always think about electrical activity in the heart always precedes or comes before muscle activity. So we must have electricity, and the reason why we said it's intrinsic, it's not really controlled by the nervous system in the body, so it's just built into the heart. So electrical activity always precedes or comes before muscle activity of the heart. So some parts or components to this electrical conduction system, you start out with the SA node, and it is located in the right atrium of the heart. So the SA node or the sinoatrial node, and if you see in bracket, it says it is the pacemaker of the heart. So some of you, while in clinical, you might have seen a little device on your patient's chest, located in the right upper area of the chest. I mean, obviously look, because it could be something else, but most often it is a pacemaker. So if this node ever happens to fail or not work properly, the heart will not function properly. And so for those patients, they go in to get an artificial pacemaker put in. So this SA node or the pacemaker, this is the driving part. And so this is what gives us that heartbeat, or what you're told normal heart rate of 60 to 100 beats per minute. Once that SA node generates an electrical impulse, that electricity gets spread or sent to the AV node or the atrioventricular node. And from the AV node, remember what we said, electrical activity always precedes muscle activity. Once that current is generated, the current is now going to spread over, not because it's located in the right atrium of the heart, it will spread over the right atrium, but it would also spread over the left atrium of the heart. Once that current spreads across both atriums, the atriums will then contract. So electrical activity first, the atriums will then contract, or they would go into systole. So the atriums will go into systole. Once they go into systole, they're going to squeeze and they're going to eject their blood into, at the same time, the right atrium will eject its blood into the right ventricle. The left atrium will inject into the left ventricle. Once they eject their blood, the atriums are now going to relax, or they're going to go into what we call diastole. That current now is going to move down the middle of the heart, and this portion right here in the middle, we call that the bundle of His, the AV bundle, or bundle of His. That current is then going to move from that AV bundle or the bundle of His into these little fibers that kind of spread on the myocardium or the ventricles, the bottom of the ventricles, and these are called the Purkinje fibers. So there are 4 parts to the conduction system. Number 1, the SA node. Number 2, the AV node. Number 3, the AV bundle or the bundle of His. And number 4, the Purkinje fiber. When the current moves to number 3 and number 4, then what that is going to do, the current is spread over the right ventricle and the left ventricle, and our ventricles will now go into systole, meaning they will squeeze and they will eject their blood. So if you recall from our previous slide, the blood from the right ventricle, that deoxygenated blood, is going to the lungs via the pulmonary arteries, and the oxygenated blood from the left ventricle will be squeezed out into the aorta, going to the rest of the body. Once the ventricles finish their systole, ejecting their blood, they will then go into diastole or relaxation, and the cycle starts all over again. So the point really looking at is this electrical conduction system must work, because without electrical activity, we don't have muscle activity. The heart will not be able to contract. So the myocardium, or the muscle of the heart, relies on this electrical conduction system, on your SA node, your AV node, the AV bundle, and the Purkinje fiber, in order for the muscles to contract. So just to quickly recap, going back to the previous slide with the electrical conduction system, when the SA node fires and that current gets transmitted to the AV node, subsequently then to the AV bundle and then the Purkinje fiber, what's happening there is something called depolarization. So depolarization will then trigger a mechanical activity or muscle activity, which is systole to occur in the heart. When they lose the current, we call that repolarization. And repolarization equals relaxation. And so that's when the heart goes into diastole. So always remember, when the SA node fires, or that pacemaker, that current then goes to the AV node. What it's causing is depolarization of both atriums. Remember, not just the right, because the SA node is located in the right, but it's causing depolarization of both atriums, which will then cause them to contract. That's your mechanical activity. Once they lose the current, they go into repolarization or relaxation, which is diastole. The current then goes to the AV bundle and the Purkinje fiber, causing systole of the ventricles, both ventricles, and then once they lose that current, they go into diastole or relaxation. They repolarizes. Now, a key thing to mention here, the heart, whenever it relaxes, filling occurs. So a heart would only fill when it goes through diastole. So that's something to start think about. Our heart beats 60 to 100 beats per minute. So when the atrium goes into diastole or relaxation, and that current is moving from the AV node into the AV bundle and the Purkinje fiber, those atriums are starting to fill. When your ventricles relaxes, they're starting to fill. And it is important. So contraction of the heart is important, but so is relaxation. Because if the heart doesn't relax, it doesn't fill, and there is nothing there to pump out. So always think about it is important for filling to occur in order for the heart to have enough blood to eject from there. So how do we understand, or how do we know the efficiency of, or how effective the heart is working? Is it effectively pumping? How do we know that? And so there's one thing that we measure, or we can measure clinically, is the cardiac output. And so cardiac output is really looking at how efficiently the heart is working as a pump, the mechanical ability of the heart to pump out blood. And so cardiac output often, yes, it's referring to both the right ventricle and the left, but when we speak of cardiac output, really what clinically what we're measuring, or what we're looking at, is how well that left ventricle of the heart is working. Because remember, we're most concerned with the left ventricle, because the left ventricle is pumping blood to all of the organs, to the body, to the systems. And so when we look at the heart's mechanical efficiency, we're really zooming in on the mechanical function of that left ventricle of the heart. So let's take a look at the definition of cardiac output. Cardiac output how can it best be defined? It's the amount of blood that the heart ejects every minute. So that volume of blood that is being ejected from the ventricles every minute. And there is a formula that is used to calculate cardiac output. Heart rate multiplied by stroke volume. So in our next slide, we are going to define stroke volume. So as mentioned before, cardiac output is really important, especially when we look at the volume that is being ejected from the left ventricle of the heart. That really tells you what is being sent to the systems to perfuse tissues and organs. And so what are some factors that can affect our cardiac output? So obviously heart rate is one of those things that can affect your cardiac output. Stroke volume, as you can see, which we'll talk about what is stroke volume. Contractility of the heart, and rate and contractility is two different things. So heart rate is how fast the heart is beating. So is it beating 100 beats per minute, 150 beats per minute, 200 beats per minute? Contractility is the squeeze. So how hard is that muscle squeezing? And that's your contractility. And there's two other factors that would affect cardiac output that we'll also define in a minute: preload and afterload. But before we get to preload and afterload, one thing I want to just identify is going back to heart rate and contractility. Throughout the course, or throughout looking at the cardiovascular content, we'll be looking at medication that can affect the heart rate and can also affect contractility. So there are medications that can increase heart rate or decrease heart rate. Likewise, there's medications that can increase contractility or decrease contractility. Medications that will affect the heart rate, we call them chronotropes. Medication that can affect contractility, we call them inotropes. When a drug increases heart rate, it is a positive chronotrope. When a drug decreases the heart rate, it's a negative chronotrope. So let's give, for example, something like epinephrine. Epinephrine will increase your heart rate. It is a positive chronotrope. Something like a beta blocker, so OLALs. So think about beta blockers that you covered when you did the hypertension content in your previous course. That will be considered a negative chronotrope. Same principle applies to inotropes. So medications that would increase contractility are called positive inotropes. So they increase the contractility, meaning they make the squeeze stronger. And medications that decreases contractility are negative inotropes. And so we would look at medication that are considered positive inotropes. Beta blockers that you're familiar with are negative inotropes. So in the previous slide, we looked at the definition of cardiac output, and we defined cardiac output as the amount of blood that is being ejected from the ventricles every minute. Stroke volume is the amount of blood that is being ejected from the heart with every contraction. And so when we look at stroke volume, it's about 70 to 80 mils of blood that is being ejected from an adult heart in one contraction. Similarly, as in our previous slide, we're going to look at some factors that would affect stroke volume. So we said some factors that would affect cardiac output is heart rate. Stroke volume would also affect cardiac output, contractility of the heart, preload and afterload, which we mentioned. And so the factors are pretty much the same. So things that would affect stroke volume are preload, afterload, myocardial contractility. And just to quickly recap, we said medications that would affect heart rate, we call them chronotropes. Medications that affect contractility are called inotropes. So in our next slide, we're going to then now define preload and afterload. We're now going to take a moment to define preload and afterload and how it applies to the principles of the heart. So when we look at preload, the definition of preload is really the volume of blood in the ventricles, so that's left behind in the ventricles at the end of diastole. So when the heart relaxes, the amount of blood that is left in the ventricle, that is referred to as preload. So as you can see, I wrote preload on the right side of the heart. And so this is, as I said, a textbook definition. If we're really looking at preload, preload is really the volume of blood that the heart is receiving. In other words, preload can be used really to say it is venous return. And when we look at venous return, we think about veins. And when we think about veins or venous return, we're thinking about the right side of the heart. So we're really looking at right side of the heart. So what's coming back when we talk about preload, we really want to focus on that right side of the heart. So it is the volume of blood in the ventricles at the end of diastole, but really it's that volume of blood that the heart is receiving. And so we want to think about that volume that is coming back to the right atrium of the heart, and then it's going to go into the right ventricle. Okay. Afterload, on the other hand, is not so much volume now. So with afterload, what we're referring to here is workload. So anytime you think afterload, you want to think workload. And the definition of afterload is really the resistance that that left ventricle has to overcome in order to eject its volume. So the resistance the left ventricle overcomes to eject its volume. So how hard this left ventricle has to squeeze to eject its volume. And so if you recall, where is this blood going to? From the left ventricle, the blood is going to go through or open up, if you recall, that aortic valve. And then the blood is then going to go into that massive vessel, the aorta. So how much force that the left ventricle has to squeeze in order to open the aortic valve and eject its volume into the aorta is the measure of afterload. So anytime we think afterload, we really are now trying to focus on the left side of the heart. A for afterload, A for arteries. So what's happening in the arteries? What's happening to that aortic valve that will make afterload either increase or decrease or stay normal? When we look at our venous return or our preload, remember we're now going to think of preload as venous return, or what's coming back to the heart, the volume. And so venous return, V for venous return, V for veins. And so now we're going to want to start to think about things that will happen in the vein that will either increase or decrease our preload. So anytime you hear the word preload, we're thinking volume. Anytime we hear the word afterload, we're thinking resistance or workload that the heart has to do. So let's troubleshoot some things that what might happen in the vein to increase our preload or venous return. So we know obviously volume. If you have a lot of volume, increase in blood volume, then technically your preload would also be increased. But let's look at the vein in itself. So we know veins are not as strong as arteries. They have valve or one-way valves that help to push the blood from the periphery back to the heart. So think about for a minute, if you have a vein that is vasoconstricted versus a vein that is really vasodilated, how might that affect preload. So we have one vein that is vasoconstricted, and we have a vein that is vasodilated. And just remember, there's not a lot of strength in veins. So a vein requires the assistance of muscles in order to send blood back to the heart. So we need muscle contractility to kind of squeeze veins and push blood back. So when you have a constricted vessel, what do you think, or how do you think that might affect preload? So if you're thinking the vessel is constricted and it's pushing, so it's like milking that vessel, and it's going to increase the volume that is going back to the right ventricle of the heart, you're correct. So constriction will, in veins, will increase your preload. Whereas if you vasodilate a vein, it means that the blood or oxygen poor blood will be pooling in that vein, and it's not returning properly to the right atrium of the heart. And as a result, that would lead to a decrease in preload. And so these concepts become very important when we look at medications or pharmacological agents that are used in the treatment of coronary artery disease in week 1. So again, think about constricting veins. It's like you're squeezing a vein, and so by squeezing, you're kind of milking that vein and you're sending blood back to the heart, so that will increase your preload. Whereas if I vasodilate a vein and blood is remaining in that vessel and it's not returning effectively to the right side of the heart, that will drop your preload. Let's move over to afterload. And so now we said afterload is no longer volume, but rather the resistance, or the amount of power that that left ventricle has to exert in order to open that aortic valve and eject its volume into the aorta, then into arterioles and arteries and to the rest of the body. So what might happen, or what can cause that left ventricle to really have to exert a lot of force? And so if you recall, blood that is being kicked out of the left ventricle is eventually ending up into arterioles and arteries and then to organs. So sometimes we can see changes in these arteries or arterioles, and going back to similarly with our veins, we can see arteries that are vasoconstricted, so really, really narrow, tiny vessels, and we can also see arteries that might end up being a bit vasodilated. And so when we look at an artery that is dilated versus one that's constricted, we want to look at resistance or workload. So think about, the way I always put this into perspective is think about the different needles you have in clinical and the gauges of the needle, and try to push fluid through it and see the kind of resistance you would feel. But just let's take a moment right now. So if the left ventricle was sending blood out into artery A that is constricted, so it's really narrow, and we're going to eject our cardiac output, which will say about 5 liters of blood, and we're trying to push it through all of these little tiny vasoconstricted arteries. Do you think you have to work hard or not so hard? And if you're saying you have to work hard, then you are correct. So your afterload is going to start to increase. Your workload, how much you have to squeeze, you're going to have to squeeze harder. Versus if you are pushing blood in a dilated artery, you're not going to need to use the amount of force to open up that aortic valve and eject that volume. So constriction in arteries would increase our afterload, and dilation in the artery will decrease our afterload. Now don't get me wrong, the artery has to provide a bit of resistance to that left ventricle, because then the left ventricle will not contract and exert force to open up the aortic valve to eject its volume. So we don't want any We don't want no resistance. There has to be some amount of resistance, but this is scenarios that we're looking at where the arteries are way too constricted or they're way too dilated. And as a result, your afterload is going to go up, meaning that the left ventricle is working way too hard if those vessels are vasoconstricted. So where I'm going to ask you to review is going back to primary or essential hypertension that was covered in your previous course, and look at what is happening to the vessels when a person has essential or primary hypertension. The vessels are vasoconstricted, and as a result, there is increased workload on that left ventricle, and start to look at what was the outcome of that increased workload on that left ventricle. So what we're now going to look at are features of the cardiac cell, and there are 4 features of the cardiac cell: automaticity, conductivity, contractility, and refractoriness. So first we're gonna discuss automaticity and refractoriness, but let's look at conductivity. We already know that the heart has an intrinsic conduction system, and once the SA node generates that electrical impulse, that impulse is conducted to the AV node, then it gets conducted to the AV bundle and the Purkinje fibers. So the myocardial cells have the ability to conduct electrical impulses. Contractility, we said once there is electricity in the heart, then we will have mechanical activity, which is contraction. So myocardial cells have the ability to contract. Now let's look at automaticity. And so automaticity is the ability of the cells within the heart to spontaneously generate an electrical impulse. So we know that the pacemaker cells have the ability to do this, but so are other cells within that myocardium of the heart. So any cell within the heart has the ability to generate an electrical impulse. So let's say there's a cell up here that is not part of that conduction system. So it's not part of the SA node, it's not part of the AV node, the AV bundle, or the Purkinje fiber. For whatever reason, gets excited and gets stimulated, it will generate an electrical impulse, which will then get transmitted through the conduction system, and we will pick that up. And that is one reason for presence of arrhythmia in your clients. The word refractoriness, and so what does refractoriness means? It means that the cardiac cells will not respond to any stimuli, so any additional stimuli, once they have been depolarized. So the cardiac, they have the inability to respond to any stimuli following depolarization. So that's a built-in mechanism for this. So the 4 features are automaticity, the ability to generate an electrical impulse spontaneously. Conductivity, some textbook will call it excitability, is the ability of the myocardial cell to respond to a stimuli by the pacemaker. So we already discussed that before, SA node to AV bundle, and then Purkinje fiber, to contract and conduct, and then refractoriness. So there's some key receptors, and understanding these receptors will help you with medications, possibly for throughout the course. And so when we look at the sympathetic nervous system, there are really 4 receptors. They're beta 1, beta 2, alpha 1, and alpha 2. I didn't really put the alpha 2 there. And so a couple of things to look at is where are these receptors located and what happens when they get stimulated. And so a couple of ways to remember this is beta 1 receptor is located in the heart. So you have one heart. So beta 1 receptors are located in the heart. Beta 2 receptors are located in lungs. You have 2 lungs, so your beta 2 receptors are located there. And alpha 1 receptors are located in blood vessels And later down, we'll also realize that it's also located in the neck of the bladder. So by the urethral sphincter, that's where alpha-1 receptors are located. When we look at the parasympathetic nervous system, we look at cholinergic or muscarinic receptors, and these are located multiple areas throughout the body. So what attaches to beta-1, beta-2, and alpha-1 and alpha-2 receptors? So if you recall, catecholamines, so epi and norepinephrine, are released from the sympathetic nervous system. So we're going to call them catecholamines. Or epi and norepinephrine are located in or as part of the sympathetic nervous system. And so what happens when they start to attach to these receptors? So if catecholamines attach to beta-1 receptors, what is the effect? And so what it starts to do, it will increase the heart rate and it will increase contractility of the heart. When it attaches to beta-2, it will cause, remember these beta-2 are located in the bronchioles, it will cause bronchodilation to occur. So it dilates the bronchioles, making it better for you to breathe. When it attaches to alpha-1, what it does now, it's going to cause vasoconstriction of these vessels. So these are good things to start to, from an anatomy perspective. So beta-1, once catecholamines are attached, increase in heart rate, increase in contractility. Beta-2, bronchodilation will occur. Alpha-1, it will result in vasoconstriction of the blood vessels. What attaches to cholinergic and muscarinic receptors are our acetylcholine, so ACH. And so the effects of when acetylcholine binds to these receptors, we start to think rest and digest. So some of the effects of acetylcholine attaching to these receptors will be increase in urinary output, increased peristalsis, so you're going to have more bowel movement, increase in secretions, increase mucus, decrease in your heart rate, decrease in blood pressure, okay? And so as we progress in the course, you might see that your patients will be receiving medications that are considered anticholinergics. And that's where it comes from. So anti these receptors. So you're going to think about what are the effects of acetylcholine binding to cholinergic receptors. So my urine output is increased. There's increase in peristalsis, increase in bowel movement, increase in secretion. So very moist mucous membranes, decrease in the heart rate, decrease in the blood pressure. So if we were to block acetylcholine from attaching to the cholinergic receptors, then all of the effects will be reversed. Now I will not be able to have urine, so I'll have urinary retention. I will have decreased peristalsis leading to constipation. I will have dry mucous membranes, increase in heart rate, increase in blood pressure, etc., etc. So you're going to use this as a base to now apply to primarily pharmacology. So as we're wrapping up this segment, we're just going to do some bridge the gap. And so taking the concept that we've done before, vasoconstriction of arteries, how might that affect our afterload? So remember, A for afterload, A for arteries, we're thinking left side of the heart. And so if I vasoconstrict my arteries, what will that do to the afterload? And if you say increase afterload, you're correct, because there is going to be increased resistance. And remember, afterload is workload. So if the arteries are vasoconstricted, they're narrow, the left ventricle has to work harder to open up that aortic valve to eject its volume. So the afterload goes up. Second, vasoconstriction of veins. What will that do to the preload? And so we're thinking V for veins, V for venous return, right side of the heart. So again, if you say vasoconstriction of the veins will increase the preload, you are correct. Remember, we talked about that squeezing motion, bringing blood back to the right side of the heart. A drug that can increase heart rate will be called what? So if you recall, drugs that affect heart rates are called chronotropes. That's correct. And because it's increasing the heart rate, these are called positive chronotrope. A drug that decreases contractility is called. So drugs that affect contractility are called inotropes. And if they decrease contractility, they are called negative inotropes. So as we're wrapping up this segment, we're going to look at factors that would increase the workload on the heart. And so this is really important because once we tie this into our content with coronary artery disease, we'll see that especially if a patient has had an MI, it means that there is damage to the heart. And if the heart is damaged, we don't want that damaged muscle to work really hard. So first, what we'll do is identify factors that would increase the workload on the heart, and then we'll look at how can we reduce that workload using pharmacology. And so if you think for a second, what are some factors that would increase the workload? One of the very first things we talk about is heart rate. And so the faster the heart beats, the more oxygen the myocardium is going to require, and the workload of that heart will be increased. So heart rate, an increase in heart rate will increase the workload on the heart. It requires, or it will demand more oxygen. The myocardium will start to demand more oxygen. Second, contractility. And so we said contractility is a bit different from heart rate. So rate is how fast it's going. Contractility is that squeeze. So the harder the squeeze, the more oxygen is going to be utilized to maximize that contraction. So again, it increases oxygen demand and myocardial workload. Preload. And so if you recall, what is preload again? It's volume. It is venous return. Yes, it is the amount that's left at the end of diastole, but it's really the volume that's coming back to the heart. And so if you remember Frank's Sterling law, when blood is coming back to the heart, the more blood that comes back, the more it's going to stretch. So think commonly about water balloons that you have during summertime. The more you fill them, the more they're going to stretch. The heart is not any different. So when you increase your preload, increase venous return, it means that the heart is stretching. The more the heart stretch, the harder it's going to snap to contract. And it means that it's going to be utilizing more oxygen in order to contract, to push that volume out. And then lastly, afterload. And remember, we said afterload is not volume, but rather it's resistance. It's workload. So the amount of force that left ventricle has to exert in order to eject its volume. So if the afterload is high, so again, think about some things that will make that afterload high. And one of those things we've identified is if the arteries are vasoconstricted in the body, giving too much resistance to that left ventricle, the more the afterload or the higher the afterload, it means that the more energy that left ventricle would have to exert in order to eject its volume. And the more resistance it's faced with and the harder it has to work, the more oxygen it's now going to demand. So these are some key factors that will increase myocardial workload. And so tying it back again, when your patient comes in with coronary artery disease, especially if they had suffered a heart attack or a myocardial infarction, we want to pay close attention to these factors, as we would want to control them or minimize them, because we don't want this damaged heart to be faced with an increase in workload. So this brings us to look at the coronary artery disease, and really what it is, it is disease of the coronary arteries or vessels that supplies the myocardium with oxygenated blood. And really what is happening in the coronary arteries are a focal deposit of cholesterol and lipids that are not so good into the intimal wall of the artery. So we'll take a look at some of those lipids that can cause or lead to coronary artery disease. Once they form in the vessel, and they tend to have an affinity for the coronary arteries due to their location, their diameter, those lipids and cholesterol tends to like the coronary arteries and can often then get deposit, cause physiological changes to those coronary arteries, resulting in coronary artery disease. So what this diagram is showing you is the coronary arteries, which we discussed before. And so what you could see here is the right coronary artery, the left coronary artery. We're not really concerned about all of the branches. What we're focusing on is we're now going to take a segment from this coronary artery, and what this is showing you is a coronary artery that is patent. So blood flow is happening, going through this coronary artery to supply the myocardium with oxygen and nutrients. If the coronary artery was to have a buildup of cholesterols and lipids, then what you're now going to see is a coronary artery starting to resemble B. And what you're seeing here, that yellow stuff that's building up there, that's plaque. And the amount of plaque that builds up in that coronary artery will give us the degree of blockage or occlusion that we're seeing in the coronary artery. So often what we could see is partial occlusion. So in this particular diagram, where you're seeing some blood is able to still kind of get through the plaque, that is a partial occlusion. If there was no blood being able to get through that plaque, we would say that's a total occlusion of that coronary artery. And so as you can imagine, if the coronary arteries are partially and or totally occluded, less blood is getting to the myocardium that this coronary artery is supplying blood to. And so at rest, there might not be an issue. But if the heart is faced with increased demand, so going back again, think about the four factors that we said could increase the workload on the heart. Increase in heart rate, increase in contractility, an increase in preload, an increase in afterload. So if those factors are increasing the workload of the heart, and the heart starts to, or the myocardium starts to require increased oxygen demand with an occluded artery, that coronary artery will not any longer be able to supply the myocardium with its required oxygen. So then you want to ask yourself, so how do I know? How does this manifest itself in the patient? Well, that's when the patient starts to experience chest pain or angina. So angina or chest pain is really a symptom or an indication of hypoxia to the myocardium of the heart. It is telling, or it's communicating to the patient there is something that's wrong when they start to experience pain. And that's why most often patients with coronary artery disease will experience chest discomfort, chest pain, with an increase in myocardial cardiac demand. Now, I'm not saying that there is never any instance where a patient can just be at rest and start to experience cardiac tight chest pain, but most often is when there is an increase in myocardial workload, when the heart or the myocardium is demanding more oxygen, and these occluded coronary arteries can't supply the myocardium with the demand, this will now start to manifest itself as chest pain or chest discomfort. Before discussing the changes that occur in coronary arteries, one thing to point out is the inner lining or the endothelium of blood vessels are often not affected by or would not react to components that's within the plasma of the blood or within blood, such as platelets, white blood cells, or fibrinolytic factors. The only time that the endothelial lining or the tunica intima will become affected or would react to platelets or other coagulation factors is if that inner lining becomes injured. And once there's an injury, as you can recall from inflammation, once an injury occurs in the body tries to repair, and it does so by mounting a local inflammatory response, which then will be followed by healing and repair. So the coronary arteries are not any different. Once become injured, then you would expect within the coronary arteries, there's going to be some sort of repair that will occur. And so the next question to ask yourself, what or how does the coronary artery that supplies the myocardium with blood, how can the endothelial lining of those vessels become injured? So now we're going to look at coronary artery disease, and really what this disease begins with is a damage to the endothelial lining of the coronary artery. So the inner lining of the coronary arteries are becoming damaged by some factors. And as a result of that, as we mentioned in our previous slide, this then sets up a local inflammatory response within the coronary arteries. So once the coronary arteries become injured, the inner lining are damaged, then that sets up a cellular and vascular response, inflammatory response, causing a local inflammatory response to occur inside of the coronary artery. And as a result of this local inflammatory response, we're now going to have lipids that will start to deposit within the lining of these coronary arteries. So inside the lining, you're now going to have a buildup of lipids that will start to, as we saw in a couple of slides back, will start to then cause narrowing of the lumen of the coronary arteries. This buildup of lipids that is occurring is what we call atherosclerosis. And that buildup that you're starting to see inside the lumen of the coronary artery is called an atheroma or a plaque. Now, you might also see arteriosclerosis before, without the H. Arteriosclerosis, this is hardening of the vessel. And this is a little bit different. And with hardening of the blood vessels, often that could be as a result of age or uncontrolled diabetes mellitus. With atherosclerosis or atheroma, we're now looking at the lipids, high cholesterol levels that are getting deposited within the intimal lining of the blood vessel, causing them to become hardened, causing the lumen to become narrow, and therefore obstructing blood flow going through that vessel. So bringing back specifically to the coronary arteries, when there's atheroma or buildup of plaque within the coronary arteries, it means that the myocardium is now going to receive less oxygen. And so atherosclerosis is one of the leading causes of coronary artery disease. There are many other factors that can contribute to coronary artery disease, which we'll look in part 2 of this presentation. And we're going to talk more about modifiable and non-modifiable factors. But one key message to walk away with is, for most of the clients that will come in with coronary artery disease, atherosclerosis is the leading cause. So what are some factors or what are some causes of injury that to the endothelial lining of coronary arteries? So some things that can predispose or cause that endothelial lining to become injured and then set up that local inflammatory response and lipids becoming deposited and the onset of atheroma or atherosclerosis are smoking, so tobacco smoking, high blood pressure, so hypertension, uncontrolled, diabetes mellitus, infections, etc. can also contribute, but these are some of the key ones that can predispose a client to having endothelial damage to their coronary arteries, ultimately leading to the development of atherosclerosis. One of the key components of that atheroma or the plaque that is building up in your coronary arteries are lipoproteins. And so what this is showing you, there are 3 different types of lipoproteins. HDL, which is high density lipoprotein. LDL, which is low density lipoprotein. And VLDL, very low density lipoprotein. So we're really going to focus on HDL and LDL. So the high density and the low density lipoprotein. And so often you probably hear that we talk about good and bad lipoproteins. Your high density is considered to be your good lipoprotein, and your low density lipoprotein is considered to be the bad lipoprotein. Now, atheroma is primarily consisted of LDL, the bad, so the low density lipoprotein. And so one of the things you're looking at is the cholesterol component. So look at the yellow part of this core molecule. And you can see in the low density lipoprotein, 45% of that molecule is made up of cholesterol. Now, cholesterol is not all bad. We do need cholesterol, but we really only need like 300 milligrams of cholesterol in our diet per day. So what makes high density good and what makes low density bad? Well, one of the very first thing, high density has a low cholesterol component, whereas low density lipoprotein has high cholesterol component. The second thing is with HDL or high density lipoprotein, this guy will transport cholesterol. So if you have an excess, it will transport cholesterol from the tissues to the liver for metabolism. So it really transports any excess cholesterol that you have from your tissues and your organs, so they don't stay there, to the liver where it's going to be metabolized, broken down, and excreted. LDL does the opposite. So LDL would actually transport cholesterol to the tissues where they're getting deposited. So they're then going to get stored and deposited, increasing your risk for atherosclerosis. So how much cholesterol do we need and why? So your daily recommended cholesterol intake is only about 300 milligrams. And the reason why we need such a small amount is the liver is able to synthesize cholesterol and provide that overall cholesterol that we need. There is an enzyme in the body that is called the HMG-CoA reductase enzyme. And what this enzyme is doing, it is involved in the pathway that is helping with the synthesis of cholesterol in the liver. And the synthesis of cholesterol is through a negative feedback mechanism. So when your cholesterol level falls in the body, because it's been utilized, the liver is going to use this HMG-CoA reductase. It is going to facilitate a pathway that will help to manufacture cholesterol that the body needs for any metabolic purposes. We're now going to look at the pathophysiology of atherosclerosis. And so if you recall from the previous slide, we said in the coronary artery, there is going to be some damage to the endothelial lining. And we said things like hypertension, smoking or tobacco use, hyperlipidemia, diabetes, etc. can cause damage to that endothelial lining. So once there is a damage, what we're now going to have is a local inflammatory response. And if you recall, with local inflammatory response, we always have a cellular and a vascular response. Now with the cellular response, this means that macrophages are going to migrate to the site. Okay, so in the blood that is flowing through these coronary arteries might have large amounts of LDL. So we have blood that is coming through in here, and so the blood that is flowing through these coronary arteries have high levels of low density lipoprotein. So when you have a damage or you have a break in that endothelial lining, what is now going to happen is LDL will then migrate into the endothelial or the intima lining. So we're now going to have LDL that will enter the intima, and once it do so, it will then get engulfed or eaten by these macrophages. So LDL will enter the intima and then get engulfed or eaten by the macrophage. Once it gets engulfed by the macrophage, think about when you have fat at home and you kind of cool it down, it kind of become kind of white or yellowish, and that's exactly what's happening. So the cytoplasm of the macrophage is now going to start to become kind of yellowish. And once the LDL gets engulfed by the macrophage, there is going to be an oxidation process that will occur, and the macrophage will die and release its lipid core. Now, when LDL gets engulfed by the macrophage, we call these foam cells. So these guys are called foam cells. So like I said, they look kind of whitish or yellowish. So once the macrophage dies and releases its lipid core, that marks the first sign or the first physiological change to the atherosclerotic process, the formation of fatty streaks. So that's B that you're looking at. So once it releases its lipid core, you have the onset of fatty streaks. And so that's the first change that you'll see in the atherosclerotic process. Now, once you have a fatty streak being formed, you can now see that's an elevation. And so initially, it doesn't really progress, or it doesn't kind of create an obstruction to the lumen of the coronary artery. But again, it's a damage. And if you recall from inflammation in your previous course, once there is inflammation, there's going to be healing. So with that fatty streak being there, what's now going to happen, we're now going to have fibrous plaque. So fibrous connective tissue, or collagen, will start to try to quote unquote repair that fatty streak. And so it's trying to cover the fatty streak, and by doing so, now it will start to encroach on the lumen. So as you can see, very minimal in B, there's very minimal encroachment into the lumen of the artery, whereas in image C, there is much more encroachment into the lumen. So now we're starting to see a bit more occlusion to the coronary artery. Once the fibrous plaque is there, blood flow will start to be reduced, that is going through this coronary artery. And now if over time, a couple of things can happen. This fibrous plaque could rupture, or because there's an elevation now remember we said before, endothelial linings are generally non-reactive, or they do not react to the platelets in your blood, the coagulation factors in your blood like fibrin and fibrinogen. But because we now have a damage, we have an elevation in that endothelial lining, now and the potential for plaque rupture, we're now going to have increase in platelet aggregation, we're going to have activation of coagulation factors, we're going to have all of those things occurring, and ultimately what you have is a thrombus that is now being formed on top of the fibrous plaque, and we call this a complicated lesion. And with a complicated lesion, what we're now starting to see is even more narrowing of that coronary artery. So with the fibrous plaque, we can potentially have a partial occlusion, but with a complicated lesion, you might look at a total occlusion of that vessel. We've established that atherosclerosis is the leading cause of coronary artery disease, and we also know that one of the large component of the atheroma, or the plaque, is bad lipoprotein, or LDL, and the key component of LDL is almost cholesterol. So 40%, remember 40% of that molecule composed of cholesterol. So we know that high cholesterol levels then will eventually lead to atherosclerosis, the buildup of plaques in coronary artery, resulting in coronary artery disease. So there are medications out there that we refer to as our statin drugs that can help to lower cholesterol level, lower blood cholesterol level, and it does so by decreasing or controlling the rate of cholesterol production. There are many such drugs out on the market. The focus here today will be looking at the drug atorvastatin, with its trade name being Lipitor. So focus on the generic name, atorvastatin. So how does the drug work? Well, first, I want you to recall that the liver requires that enzyme, HMG-CoA reductase, for synthesis of cholesterol, or for the biochemical synthesis of cholesterol. So what does Lipitor do? It actually stops this enzyme, or it inhibits the enzyme from synthesizing cholesterol. What they're also finding is, as you decrease cholesterol synthesis, it also causes increased LDL receptors to start developing on the liver. And you're probably thinking, what is the role of these LDL receptors? So what these LDL receptors do, they help to recycle LDL from circulation, and they bring it back to the liver. And what we could use that LDL now to do is to synthesize other substances that the body needs, such as steroids, bile salts, cell membranes, etc. So the more we lower the cholesterol levels, they're finding that there is an increased production, or an increased amount of LDL receptors that are starting to appear on the liver. And what that LDL can now be, those LDL receptors do, they will start to recycle that LDL and to utilize it to make other useful substances for the body, such as steroids, cell membranes, etc. So just in wrapping up part 1, we'll just do a quick knowledge check. So the first thing is, what are the 4 factors that would increase myocardial workload? I'm going to give you a minute to just think about that. So if you come up with increase in heart rate, increase in myocardial contractility, increase in preload, increase in afterload, you're correct. So remember, these are the 4 things that we said will tend to increase oxygen demand by the myocardium because it increases the workload. So the faster the heart goes, the increased workload we'll see. The harder it contracts, so increase in contractility, the more oxygen it's going to need because it's working harder. Preload is volume returning back to the heart, and the more volume returns, the more stretch. The more stretch, the harder the contraction, increasing workload. And afterload is not volume, but rather resistance. So the amount of resistance that left ventricle has to overcome in order to eject its volume. And so the more afterload the left ventricle is faced with, the harder it has to work in order to open that aortic valve to eject its volume. So our second knowledge check question is, which of the following medication will reduce the myocardial workloads? Select all that applies. So we're not asking for specific medication here, but rather how the medication works, the mechanism of action. So a positive chronotropic agent, a venous dilator, a negative inotropic agent, an arterial vasoconstrictor, or a negative chronotropic agent. So if you've picked B, C, and E, you're correct. So a couple of things, let's go through quickly. Remember, a chronotrope is a drug that will, or an agent that will increase the heart rate. So a positive chronotropic agent means that this drug will increase the heart rate. And the question is asking what would help to reduce myocardial workload. So if the heart rate goes up, the myocardial workload will be increased. Venous dilator. So this is a drug that will help to dilate veins. Always think about veins, V for veins, V for venous return. We're starting to think preload. With the venous dilators, remember what we said. When veins are constricted, it increases the preload because we're kind of milking that blood back to the heart. When we dilate a vein, blood will be pooling in the periphery, so it means that my venous return is reduced. If we have less going back to the heart, it means less stretch on the heart, less workload. So B is correct. Inotropes are agents that affect contractility. So a negative inotrope is a drug that will reduce myocardial contractility, and so if it's not contracting as hard, the workload would also be decreased. An arterial vasoconstrictor. So A for artery, A for afterload. And if I make my arteries narrow, what am I doing? I'm actually increasing afterload. So I'm increasing resistance that left ventricle will have to overcome to inject its volume. An increase in afterload means that the heart will be working harder, not less. So D is incorrect. And a negative chronotropic agent, which we kind of addressed in A, this is an agent that again now will decrease the heart rate rather than increase. And so by decreasing the heart rate, we are reducing myocardial workload.